Hey, thanks so much, everybody, and welcome to GM Insights. We're really glad to have you here with us today. Today we have Dr. Carolyn Clevenger, who is a professor of clinical track and associate dean for transformational clinical practice, also known as my clinical boss. And so we're really glad to have her here, and it's a real pleasure. So I'm going to take down this slide, and Carolyn, we'll let you go ahead and get started, and you can share your deck.
Sounds good. Hey, everyone. Thanks for joining us in the middle of your workday. Glad to see you. So we're going to talk about staging tools in dementia. I'm going to try to make this as practical as possible, but I do want to expand some horizons and just increase awareness of some of the tools that are out there for you. And I'll show you some of the ones that we use here at Integrated Memory Care. And my colleagues are here to keep me honest. Quick disclosure, I don't have a disclosure related to this particular talk, but I do some work with OTSCA and on their advisory board. So what we want to cover today is really why we stage in the first place. I just had a conversation with someone in the system that we like to think about the purpose of what we're doing, and then we can think about the strategies. So I want to begin with that, and then I'll show you some different approaches, and each of them come with pros and cons of different methods that you might have in place. And it's going to, of course, depend on your practice, your patients, and your resources. So I thought it would be helpful for me to know if we start to understand, are you currently using a staging tool in your practice at all? Sometimes, half the time, always. Feel free to put that in the chat. And I can actually see chat while I'm sharing, which is handy. Dr. Mark mentions the FAST scale for hospice eligibility. Glad you mentioned that. We will talk about it. I see sometimes, not much. Okay. And a similar question as you're jumping in the chat. What is it that you would like to know? Why would you like to know more about this topic? What prompted you to attend today, other than Ted's very encouraging recommendations on maybe your morning huddle? Important to families. Some people say important to Ted, important for our documentation, certainly helpful for families to understand where we go from here, and definitely to inform your treatment plans. These are all great reasons. Good. Well, I think hopefully we'll address each of these. So I actually want to take us back to the cognitive assessment and care planning visit, if that's something that you're doing regularly in your practice. There are sort of core elements just based on clinical guidelines. And of course, those match up with what CMS requires in your documentation. So remember, dementia as a syndrome is 3 components. It is cognitive, behavioral, and functional symptoms. That is the syndrome we're looking at. Some of the guidelines have a lovely mnemonic of CBFS. So this is a cognitive, behavioral, and functional syndrome that we're talking about. And part of our core elements and best practice is also to look at caregiver symptoms as well. But what we're going to focus on in terms of staging is really about function. And I'll share with you why. So first of all, why do we do each of these assessments? I know sometimes we are maybe doing a functional assessment along with cognitive and hopefully neuropsych as well as we're screening people. So as part of our network here, maybe this is what prompts you then to refer to a memory assessment center so that people can further be diagnosed. And as part of that diagnostic process, whether you're doing it in your practice or referring out, these are the tools that we use to measure objectively their symptom burden in each of those categories. So this is part of the workup for folks. Once someone is diagnosed, though, and you're doing those ongoing cognitive assessment visits or CAVs, as we have in our visit type in the system, we want to know, okay, that was what the diagnosis was and where this person was when they were diagnosed in terms of staging. Now we want to know, where are we today? So we want to actually measure progression. Again, difficult to do that without some objective tools. So I'll show you some of those tools that I like to use. But where you may have been 3 years ago when this person had the original diagnosis, things have changed, they've evolved. And of course, your coding and diagnostic coding in particular has been updated recently to expect that you're having those conversations or considering those things. We do these assessments because we're trying to identify symptom burden especially behavioral and functional. Those are the two things, honestly, that are going to raise someone's level of care. Those are the things that are going to take someone out of their home. So the verbal, physical aggression in terms of behavioral symptoms, and then what the types of things they're able to do independently, semi-dependently, or are dependent on. Some of you mentioned this. We do this because this gives us context. It's hard to talk about what's coming in the next 6 months or 12 months, which I like to refer to as anticipatory guidance, stealing that term from our pediatrics colleagues. It's hard to have that conversation if we haven't talked about where are we today. That tells us what we can expect next. And hopefully, if we as the clinician are expecting common things that will happen in the next, again, 6, 12 months, 3 years, 5 years, if we know those things are coming, we've shared those with both the patient as much as they can engage and their care partner. Many times their functional ability lets us know what the level of supervision is that's required. So we may begin in an early stage where someone maybe needs prompting and nudging to engage in activities of daily living to the point where they actually need hands-on support, or if there are concerns around just their basic safety when they're alone. So we might upgrade our language in a care plan from provide structure, routine, and support to continuous supervision 24 hours a day. And then if you will be involved as people progress through this syndrome, which of course is progressive and degenerative. People often do transition to residential care. And the determination of their eligibility for different levels of care is very much based on their ability to care for themselves or their function. So when you're completing those papers, it makes it very helpful then to have had a recent assessment and discussion about what they need support with, because that is the determination, for example, for assisted living versus nursing home. So the ability to propel or ambulate oneself, even if it requires an assistive device. So then why do we standardize the assessment? I think we've hopefully considered this before. When we look at our clinician judgment, which can be very helpful and meaningful in interviews and working with patients with the Gestalt, you really want to use a standardized tool. Also, when someone can actually see, my score was a 30 last year, and this year it's a 36 on something like the Dementia Severity Rating Scale, that may be another piece of information that is helpful for families, maybe patients, to sort of understand and grasp in terms of when we say things have progressed, things have worsened, that can actually put a number to that worsening or progression. For us, it lets us not only that they have had change over time, but how much. And again, we know sort of what is expected progression and what looks like maybe a rapid or a slower progression. And most of the time, and I'm going to show you some caveats today with functional assessments, when someone transitions, let's say from Mayo to us, from us to another practice, this is more easily interpreted between clinicians when you have a measure versus, your commentary in a note that they have progressed to, more dependence or something like that, that is more qualitative as opposed to quantitative. So some of you mentioned already you're using, for example, FAST scale for specific reasons. Some people are not using this too much. I'm going to go right past this and actually get into some of the tools that you may have available to you. And, as much as we like to complain about our electronic medical record, a lot of this may be driven by what's available to you in your electronic medical record out of the box, or maybe what you can potentially build or put in place. I'm going to start with the functional activities questionnaire because this is something our cognitive neurology team has actually recommended to primary care for years as part of screening tools that may be helpful because it is brief and because it is relatively easy to interpret. Ted has done a very kind thing for me and put each of these links as a QR code so that you can actually open the actual tool. Many of them are hosted on the Alzheimer's Association site, so you can actually see the questionnaire for yourself. I did not necessarily put each of the questionnaires in, although I think some of them are here. So this is observer rated. And I think that's important to mention for, I think every tool, nearly every tool, if not every tool I'm going to talk about today, is observer rated. That's how the tool is validated. This is not about a patient determining or reporting their own impression of their ability to complete these tasks successfully, which I hope underscores for you the value and the critical need for bringing in either an informant or care partner / caregiver as part of your practice and your workflow in or before the visit. So this is a person who's going to report on their ability to perform a multitude of functional activities, both basic and instrumental ADLs, and you have a range of scores. So it can be they can complete it completely independently, no difficulty, up to unable to perform the activity. So that's much easier than some of the older tools that are out there, which were basically a 0 or 1. They either can do it or they can't. There's a lot of gray, obviously, between those two. This is a screenshot of what that FAQ looks like. And so this is something where you're asking the informant to rate, and you've got your scale here. And then it's just this list of these 10 activities. So I think, honestly, of all the tools I'll share with you, this is the most brief one to put in place. And so very much more practical. The Lawton-Brody scale was a unique experience for me. We used this. This is actually in our EPIC system at IMC and other practices around Emory, because it was built already for us. It may be listed as something like neuro, but anyway, when you search IADL questionnaire, it does come up in your questionnaires or flow sheets. So it covers both, of course, instrumental and basic. And here's just a list to remind you of what is included in those categories. And it also has a range. So let me say this. It is used differently in different systems. So when I pull this up, I can find versions of it that are basically 0 or 1, and I can find more granular graded types of opportunities. So this is one where you don't necessarily, the challenge, of course, is then sharing that between health systems is not as simple because it's not standardized in the scoring. But for your own system, so within your health system, and then comparing the patient to themselves, you of course still have the benefit to see their change over time, which is really, I think, one of the most important pieces. Fun fact about the Lawton-Brody scale, though, and this was a new finding for me really in the last month, doing this work for 20 years. A month ago, I found out that the original publications had different scales and score thresholds by gender. Of course, it was male, female. There was no category for other categories for gender, but basically that men were not expected to know how to cook, do laundry, or clean. So glad we've passed that. This is a screenshot of what it looked like, and this is actually how we use it in our practice at IMC today. And then, of course, what's in EPIC for us is just an electronic version of this same scale. I will also say, in terms of totaling the scores and then equating this to stage, I have done, this is my own work. I wouldn't, like, it's not validated in this way, but I would be glad to share with you if you want to see how I have scored the range here for people who are early, moderate, and late stage dementia based on cutoffs using the scale like this. So if you're one of my colleagues using this scale, glad to share. I feel strongly enough about it that we did use it for a case-controlled study of our patients compared with other primary care patients. And so that's going to go in our peer-reviewed publication at some point. But in the meantime, just ask me if you want to use this particular one and you want to determine stage based on that.
Carolyn, thinking about patients that you see, what are some of the first things that are lost in that last IADL scale?
Yeah, so regardless of gender, you're going to begin with seeing changes in instrumental activities, right? And so, in fact, for people who are calling our clinic, we're asking things like, are they doing some of these instrumental activities by themselves? If they don't have a diagnosis, a good diagnosis of dementia, lets us know. And by the way, I will just say, we do know in terms of published literature, patients being diagnosed in primary care settings are middle stage, moderate stage. So honestly, by the time people get to us, they're probably, several of these have been diminished. And I think some of that depends on what's a learned behavior. I have people who, cannot manage dialing the phone, could not be managing finances, certainly like household finances or preparing meals. Medications are a little bit spotty, but they still do all the laundry in the house with expert touch. So, some of this is going to be individualized based on their own learned experiences and things that they like to do. Thanks
for that.
Some of us may hope, if we are unfortunate enough to develop a dementia syndrome, that we lose laundry abilities early. So if I look at FAST, and Dr. Merck mentioned this one specifically, I will tell you in terms of functional assessment staging tool, and I didn't get into this because we have a brief time together today about why function is really predominantly used for prognosis, not just in dementia syndrome, but in most life-limiting illnesses. So if you hadn't, ever wondered, the main staging tool to make someone eligible for the Medicare benefit of hospice, it is to use the functional assessment staging tool. Pros and cons, like I said, with all of these, This is a scale that goes from 1 to 7. When you start to get into the higher numbers, 6 and 7, you have more granular expectations. So there's 6A through F and 7A through F. I'll show you that in just a second. 1 is obviously no impairment, and things sort of progress from there. This is an image of what this looks like. I think what's been challenging for most people when they look at the FAST scale is that, especially earlier on, so in 5, requires assistance in choosing proper clothing. There are some people who are fairly early in their disease stage who could use some help picking out their clothes. There are some people who are pretty advanced who do a fantastic job and still come into your clinic dressed to the nines to come see the doctor today. So it was a little frustrating, I think, earlier on. Where you're really going to see the FAST used, to be honest, is going to be exactly like Anna said, which is that hospice eligibility. So your patients would be eligible at stage 7 and beyond. Maybe earlier on, you might be having a conversation about their eligibility for something like palliative care as opposed to hospice. This might be a helpful way to document. I can assure you, if you refer someone for an evaluation to hospice and the hospice nurse comes out to consider them for admission, this is the tool they're going to use to evaluate your patient. And I know sometimes it can be really frustrating. Maybe you've had multiple conversations, you've gotten the family to a place where they're accepting of hospice services, and hospice goes out and says, nope, not eligible. You can save probably yourself and that family quite a bit of angst if you are documenting this more consistently and you're sending it over, so that it makes their job a little bit more clear based on what you've seen, having a relationship with this person as their primary care provider over years potentially, versus what the hospice person may come out to see. Sometimes they get there, they talk to the family, don't necessarily talk much or evaluate the patient closely. And the family may have a day where they're like, no, they're doing all the things. And, we know they're not doing them or doing them successfully. So that's, I think, a value add for FAST. But I don't often see us using that as a standard tool, but I wanted to make sure you knew about it. This is a tool that we use in IMC. So this means it's built in the Emory Epic version called the Dementia Severity Rating Scale, or the DSRS. This is a more global assessment. I had one more I almost showed you, but there are a couple scales like this. This is, again, informant rated. So this is someone who has exposure and observation of the person's abilities. It's going to be more global, meaning there are questions about someone's thinking or obvious outward exposures of how they're thinking, or their memory or their judgment is impaired. Their behaviors or neuropsych symptoms, and then their functional symptoms. I find it a little bit more in real life kind of questions that we're asking families, as opposed to maybe something like a more standard neuropsych testing. This is sort of like, how do they function in their world? And I think that's the value of these global assessments. As an aside, I'm not going to go into it today, but you have heard in this lecture series about the clinical dementia rating scale. It is similarly very global, and it captures kind of pieces of all of these. For us, we use this specifically when our patients are doing a cognitive assessment visit, but can no longer complete neuropsych testing. So if we know that their last MoCA was less than 10, I don't expect a year later that that's going to be a successful encounter for them to have those questions in front of them. I think it leads to a lot of angst and frustration. We all have patients who practice their MoCA questions for the whole year before they get back to you. And frankly, I think it's a major cause of no-shows when people get anxious or frustrated from these testing. So DSRS does not require any testing. It completely comes from the informant. It does have score cutoffs that are validated as part of the instrument to let you know around stage. And I would say, I feel pretty confident that the DSRS typically represents what I would have said was my clinical gestalt about this patient's stage. Now, you may have seen on your MoCAs or any other cognitive test you're doing. I know no one's doing MMSE or SLUMS, but they also have cutoffs by stage. I do not find those helpful at all, but this does tend to correlate with what I call IRL, in real life, as the kids say. So this is a quick screenshot of the first and last page from the DSRS, but you can kind of see it starts with some cognitive questions, and it asks things like how they get from place to place. It'll ask about continence, ability to do self-care, engagement with social activities. Again, sometimes remember, asking these questions of an informant is almost an intervention itself, because it does tend to improve their own awareness of, oh yeah, I did notice that they do or don't do these things anymore. So anyway, that's another pro, I would say, of all the scales, but this one in particular, because it's so global.
Hey, Carolyn, if we could go back for just a second. So
Okay.
Birju Patel put in a really good comment about thinking about the FAST versus the dementia severity rating scale in a way, because the FAST is kind of hierarchical. You just go from 1 all the way down to 7E. And what if you have one element of 6 and one element of 7B? And there's incontinence in Birju's point where that's not necessarily going to put you in 6 if other things aren't there. And this is kind of additive that goes across all scales. So just your thoughts and comment about that.
What a wonderful comment. Thank you for adding that, Virgil. I should have said that. That's always been my frustration with FAST, because the each of the line items really gives you just one element, one piece of their function. And as we said earlier, people have deterioration in different activities based on all kinds of other factors. So I think that's always been the frustration, to say, okay, they're like, mostly in this stage, but they've got 1 foot in stage 5 and 1, foot squarely in stage 6. And where do you sort of put them in that scale? That's always been a big frustration of ours too. So certainly a reason really, I think, for something more global like the dementia severity rating scale, or if you are inclined to the clinical dementia rating scales, really FAST comes into play, I think, when you are looking at that, like in stage care and eligibility for Medicare benefits like hospice.
Hembar Kulresh has some great comments in the chat, and I'll highlight one of them, and we'll go back to the second one in just a moment. And that is that, where do you have time to do all this? And Chad Hales put in that some of these are already embedded in Epic, and you mentioned that these are caregiver facing. We know that portal access is a little differential by, diagnosis and age. What are some practical tips that you have for folks as to getting this important information into the record?
So let's put a pin in that. I want to show you one more thing and then I'll get to it. I love the question. I just want to go ahead and say what's not helpful. I know that's not usually the thing, but the thing is, people have experienced a couple of things, a couple of steps along the process in their diagnosis. And in other conditions, these things might be meaningful to stage their disease. So people probably got an MRI or a CT scan as part of their diagnostic workup. And we have had families who are like, well, we're here for our repeat MRI. They're not needing serial MRIs unless they're on some of the newer treatments. So just kind of keep in mind that that's not how we progress. That's not how we stage people, right? So some people's scans look really atrophied and actually they're quite functionally fairly independent, more than you would expect. That's why you can't just simply get a scan and diagnose someone. It's more complex than that. So that's something that I just kind of mentioned to you. And then the last piece is the labs, right? So people may have experienced having biomarkers measured either by blood now, which is FDA approved, but not Medicare covered, or through their CSF. And so if they're expecting, I don't know that many people are asking for a lumbar puncture, but I think once these blood tests become more available and aware, I could see people asking. The thing is, and I'm going to jump right to that amyloid piece. If someone is doing that amyloid kind of testing or those biomarker tests, remember that's something that rises and peaks and plateaus before someone ever has symptoms. It's not really expected to change as their symptoms progress. It really is the functional changes. So if people are asking for those things, that's not recommended. And hopefully it gives you a little bit of an idea of why that is. So let's talk about the workflow integration. This is the same question. And that's primary care, right? We've got to get through patients. So you have a couple of options. And my advice is this: when you are looking at, we're not doing anything, but we know that we need to, I find it very helpful to map our current process and then identify, does a step in the process need to be, do we need to add a step? Do we need to modify a step along the way? This is probably not one where we would remove a step. So it may be part of your e-check-in. So we actually have attached questionnaires to different visit types. So we know if we're doing, for example, a cognitive assessment visit, that the e-check-in for that, when those people get reminders, they're part of their e-check-in includes the questionnaires about function. And if they're doing an advanced cognitive assessment, meaning they have advanced disease and we're doing a cognitive assessment. So that's how we've ended up working it in. We have been around, IMC's been around for 7 years. There was absolutely a time when someone came to the front desk, checked in for their visit, and they got a clipboard with this questionnaire. So the informant, the caregiver would get it. We knew the caregiver was completing it, so that was kind of helpful. But a couple of downsides. For one thing, the patient might look over their shoulder and say, why are you saying those things? Who is that about? I don't agree with what you're saying. So that's challenging. The other, of course, is that then someone on our staff had to manually input it into the questionnaire answers into the medical record system. So we have done both before the visit. That is greatly preferred. We did it in the old medical record and in the new now systems. We've done it at check-in, and then at worst case, you can do it during rooming. Again, it gets a little bit sticky because you're trying to get this information from the informant or the caregiver. And so being able to do that in a way that's respectful, but also accurate, you really need to sort of figure out what works for you in terms of your timing. There are certainly practices where patients might go do something else, like maybe, you're doing labs before the visit. And while the caregiver is in the waiting room or in the room, we can do these questionnaires. But that's generally how we've incorporated into our workflow. And it's critical when you're doing a cognitive assessment visit. But your clinical guidelines say that functional measures should be conducted for people living with dementia every 6 months. That's what our quality measures say from the Academy of Neurology. Okay, so now you have this information, you have an idea where we are in terms of staging. Now, what do you do with that information? So I've been mentioning the cognitive assessment visit. That is an opportunity to clarify stage and to share that information with families, again, so that we can set the stage and context for planning going from here. So here's what I expect next. I'm sure have noticed in October of 2022, our ICD-10 codes changed to ask you to be more specific, not just dementia, not otherwise specified. So we want to know as best you can the underlying pathology. That's part one. Part two is stage. And there's not a gold standard for staging in terms of that coding. And then of course, part three is behavioral symptoms, which is beyond the scope of today's talk. If you have someone who has been paying these high premiums for long-term care insurance, or who's fortunate enough to be eligible for VA benefits or other types of resources that will help with the care that they now require, information that you're going to gather as part of your functional assessment is exactly what you're going to need to accurately complete that paperwork correctly the first time. This means thousands of dollars in support for these patients. So you want to have the information available and accurate when they're ready to activate those benefits. Of course, you've probably been asked for the PME, the Physician Medical Evaluation Form for assisted living or personal care homes. Much of the questions on there, your staff can complete for you, but it's hard to do that if they can't go back to your functional assessment and pull the information from the patient's chart. And that's, of course, going to save you time because otherwise they're coming to you for your clinical judgment there. And then, as we talked about already, for hospice referral and evaluation, specifically the FAST in that case, but it may also be helpful as you're talking about staging with the family, as we're saying that hospice is now appropriate, or hospice will be appropriate in another 6 or 12 months.
And also excuse from jury duty.
Oh, that's right. We've definitely completed a number of excuse from jury duty for the patient, but also for the care partner because they have these functional limitations. That's a great one. So a couple of summarized takeaways today. So again, dementia, remember, is a cognitive, behavioral, and functional syndrome, and the caregiver assessment is included in standard of care. So that means standard of care for these patients should include one form of these assessments. We prefer a standardized tool. It is superior to clinician judgment, and honestly, it is more time-saving in primary care, right? Because you're gathering that information as part of the visit check-in or the pre-visit planning. Most, if not all, tools are designed for that caregiver observer. So that means you have to engage them as part of the clinical process. And most of them will tell you that's exactly what they want. They want to be a part of this process if at all possible. And that is not a HIPAA issue. You're not giving them information about the patient. You're getting information from them about the patient. So don't get yourself hung up on that. And then just think scoring might vary if you do something like the Lawton-Brody tool, but standardization certainly should be local so you can at least compare people within the system or your own patient from their own performance previously.
We'll leave that last slide up. Carolyn, you killed it. Thanks so much. We really appreciate it. There are two items in the chat that we didn't get to. I don't know if you want to see them and just address them, or I'm happy to read them out loud for you.
There's quite a few that I have to catch up with. What do we have?
Sure. The last one was from Ambar. When I admit patients in the hospital, I find it helpful to see what their actual deficits are, then see the score. It can depend on who's assessing it. Agree with that comment.
Absolutely.
And then Joanna asked, when administering the DSRS, do you recommend reading all the options out loud, or ask the care partner to generally describe their loved one's abilities and deficits in each domain?
Yeah, so my preference is not to administer it by reading it out like an interview. Honestly, I really want them to complete it and see the options, if at all possible. Sometimes I get into the visit, it hasn't been completed in advance, but I also know the patient. So I'm looking at these and I know sort of where they sit between a couple of them, and I might ask the care partner then between those choices. But if you're reading aloud all of the options, this will certainly take a decent amount of time.
it'll take longer. And I really appreciate what you said earlier about engaging the care partners in this, and it just informs them to look at all the choices and options and check the appropriate ones. Terrific talk comment from Sonia Green. Thanks, Sonia. Chad Hale said that Epic MyChart proxy access is really important and helpful in completing questionnaires. And Fred Turton, thanks Fred for joining us. Can you show what tools are available in Epic and how to find them?
So I don't want to, I probably don't have time to share my screen and open it, but I will tell you in flow sheets in the search field, I've typed in NPI and it will come up, DSRS, and then ADL. And while we're here, CCC, which is Caregiver Confidence and Competence, not my favorite scale, but it's also in our Epic system.
Great, thanks so much. Really appreciate it.
Oh,
Thanks,
Epic.
Carolyn. This was a great talk. Lori Beth will be, I'll ask for her assistance in sending out a little Word document that shows you, again, each of the 4 scales that we covered, a link, a QR code, and a sample of what these look like. Please, 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 also, when we reach out to you, we're going to ask you for feedback on the session. Vote great. vote your conscience, but we're really excited and thought that this was a great talk. Any quick comments before we leave?
Chad just added FAQ is also in that flow sheet search field.
Great. Thanks so much. Hey, everybody, have a great day. We really appreciate you. We'll see you soon.
Thanks, guys.